Welcome to the deep dive. Imagine looking at a single skin biopsy, and the pathology report is basically telling you two completely contradictory things.
Yeah, a total biological paradox.
Exactly. First, it says the tissue is dissolving, actively thinning away to almost nothing. But second, it says that very same piece of skin is simultaneously building this thick, overgrown, impenetrable armor.
Which, I mean, on its face sounds impossible.
Right. So today, for you listening, whether you're prepping for a medical consult, maybe you're studying pathology, or you're just insanely curious about how the body reacts to trauma, we are zeroing in on this exact paradox.
We've got a stack of clinical guidelines and data from the International and British Societies for the Study of Vulvovaginal Disease.
Yeah, and our mission today is to answer one highly specific question. What is the clinical significance of finding squamous cell hyperplasia right alongside lichen sclerosus on a biopsy report?
What's fascinating here is that in a typical medical scenario, diagnosing something is usually pretty binary.
Like a broken bone.
Exactly. You take an X-ray, you see a jagged white line, and it's either broken or it's not. But pathology reports, especially in vulvovaginal disease, they don't work like that at all.
They're more like crime scene photos, right?
That's a perfect way to look at it. They're these frozen snapshots of a microscopic battlefield. Seeing both of these conditions coexisting on the exact same piece of tissue tells this really specific, dynamic story.
A story about what the skin has endured over a long time.
Right. It shows immense physical and immunological stress.
Okay, let's unpack this by establishing the baseline of that battlefield first. Let's look at the foundational condition. Lichen sclerosus, or LS.
Which is a heavy hitter in dermatology.
It really is. So the sources define LS as a chronic inflammatory skin disorder. It's heavily suspected to be autoimmune, meaning, the body's defense system has kind of gone rogue.
Yeah, it's attacking itself.
And it predominantly affects the vulva. The data shows it usually hits two specific groups, the hardest prepubertal girls and postmenopausal women.
And the physical manifestation of that autoimmune attack is intense. It actively alters the architecture of the skin.
How so? Like, what's happening on a cellular level?
So, microscopically, T cells, which are basically the foot soldiers of your immune system, they migrate into the dermis. And they essentially start attacking the structural scaffolding.
Wow. So they're destroying the foundation.
Exactly. The collagen gets destroyed, and the skin just completely loses its normal elasticity.
The descriptions we found in the literature paint a really clear, kind of jarring picture. It turns the skin this striking porcelain white.
And it thins it out aggressively.
Yeah. Pathologists describe it as looking like cigarette paper or crinkled parchment. And for the patient, the defining symptom is this intense, deep-seated, sometimes just totally unbearable itching.
The fragility of that environment, really can't be overstated.
Yeah.
Because that structural integrity is gone, the tissue can tear or bruise with just minimal friction.
Which sounds awful. But then on this specific biopsy report we're decoding, a second term pops up.
All right, the second half of the paradox.
Squamous cell hyperplasia, or SCH.
Historically, when pathologists looked under a microscope and saw this massive overgrowth of squamous cells, those are the flat cells making up your outermost layer of skin. They called it squamous cell hyperplasia.
Which just literally translates to, like, an abnormal multiplication of cells, right?
Exactly. Just cells dividing way too fast.
And the modern sources, like the 2006 ISSVD terminology, clarify that this is essentially synonymous with lichen simplex chronicus, or LSC.
Right, which is a state where the skin thickens dramatically, it becomes leathery, and the normal skin markings get wildly exaggerated.
So wait, here is the immediate conflict in the data. LS makes the skin incredibly thin and fragile, like cigarette paper.
Right.
But SCH means the skin is thickened, leathery, and rapidly multiplying. How can a single biopsy show severe thinning and severe thickening in the exact same spot?
It seems completely counterintuitive.
Yeah. If the skin is actively dissolving from an autoimmune attack, where is it even getting the resources to build a massive fortress of new cells? It sounds like a total paradox.
It does, but what's actually happening is the biopsy is capturing a collision. It's capturing the interaction between human behavior and the disease itself.
Human behavior.
Yeah. Historically, clinicians called this combo mixed dystrophy because they saw these two distinct features stacked right on top of each other.
Okay, so a thinned out diseased layer on the bottom.
And a frantic multiplying surface layer on top.
Which brings us to the actual mechanism of how this happens, the itch-scratch hypothesis.
Proposed by researcher Dr. James Scurry, yes.
So how does this hypothesis bridge that paradox?
Well, it starts with the underlying lichen sclerosus, causing that primary severe itch we talked about. And this isn't, a casual tickle from dry skin.
Right, the sources made it sound agonizing.
It is. It's the result of autoimmune inflammation firing off constant nerve signals in the tissue. So, in response to that neurological alarm bell, what does the patient do?
They scratch.
Exactly. They scratch. And the drive to do it is relentless. It often happens completely unconsciously, especially during deep sleep.
The clinical texts specifically mention that patients will literally wake up with excoriated, bleeding skin because their hands were just, trying to relieve that nerve firing while they were asleep.
So think about the biology of that mechanical trauma. The physical rubbing and scratching tears at the epidermis,
It shreds the skin cells.
right, the keratinocytes, but
Yeah.
those cells still have their basic evolutionary programming.
Okay, so when they get shredded, they send out an SOS.
Precisely. They sense the sheer mechanical trauma and release distress signals. That forces the epidermal cells to rapidly divide, multiply, and thicken up to create a physical barrier against the assault.
Ah, so that reactive thickening, that is the squamous cell hyperplasia.
You got it. It's built right on top of the fragile lichen sclerosus.
That makes total sense. It's the exact same biological mechanism as like building up calluses on your hands.
Yeah, that's a perfect analogy.
Like if you start lifting heavy weights or you learn to play the acoustic guitar, the friction on your fingertips shreds the skin at first.
And the body says, uh-oh, we need armor here.
Right, so it builds a thick, leathery callus of extra squamous cells to protect you. The skin is just doing its job.
It is. But the tragic difference here is the foundation.
Because when you build a guitar callus, you're building it on healthy tissue.
Exactly. In this dual diagnosis, the body is desperately trying to build heavy armor on a foundation of crumbling, inflamed, fragile parchment paper.
Man, that's just a brutal cycle. So when a clinician sees this on a biopsy, when they see LS and SCH together, what does that actually tell them?
It acts as a massive red flag. It tells the clinician instantly that this patient is trapped in an uncontrolled chronic itch-scratch cycle.
The disease is active.
Highly active. The patient is in significant physical distress, and that vital physical barrier of the skin is just actively being destroyed by disease and recklessly rebuilt by trauma over and over.
And that endless cycle of destruction and rebuilding is exactly what shifts this from just a painful condition into a really dangerous one.
Yes, this is where we have to talk about the stakes.
Right, because here's where it gets really interesting for you listening. Lichen sclerosus is officially classified as a premalignant condition.
The baseline data shows women with LS have a lifetime risk of about 3.5% to 7% for developing vulvar squamous cell carcinoma.
Which is significant on its own, but when you add the squamous cell hyperplasia to the mix, when that reactive callus forms over the inflamed skin, the risk profile demands, like, intense vigilance.
It skyrockets. In the studies we reviewed, up to 62% of vulvar cancer cases have LS, SCH, or a precursor condition in the tissue right next to the tumor.
62%. So what is actually happening on a cellular level to drive that number up so high? Like, why does the callus make the environment more prone to cancer?
If we connect this to the bigger picture, you have to look at the biochemical environment this creates. First, you have chronic, smoldering inflammation from the autoimmune disease.
The immune system constantly flooding the area.
Right, with inflammatory cytokines. Think of those as chemical flares that keep the local immune cells on high alert, which generates a lot of toxic byproducts.
Okay, so a toxic baseline. And then you add the scratch check.
Exactly. You introduce mechanical trauma, forcing the cells into overdrive to build that hyperplastic callus. They're dividing at an entirely unnatural rate.
So you have hyperspeed cell division happening in the middle of a toxic war zone.
That is exactly what's happening. And this combination creates a state of intense oxidative stress. It causes lipid and DNA peroxidation.
Lipid and DNA peroxidation. Meaning what, exactly?
To put it in conversational terms, it is essentially biological rusting.
Biological rusting, that's a terrifying visual.
It really is. The fats that make up the cell membranes and the actual DNA inside the nucleus, they're literally corroding from the stress of that inflammatory environment.
Oh, wow. And every time a cell divides, it has to copy its entire DNA sequence, right?
Right. And under normal conditions, your body is great at proofreading that copy. But when you force cells to divide rapidly for years and decades while they're actively corroding,
That probability of a copying error goes way up.
the probability of a critical genetic mutation absolutely skyrockets.
So it's a localized environment that has basically been unintentionally engineered to force a mutation. And the sources point to one specific vulnerability. the p53 gene.
Yes, the tumor suppressor gene.
So what does p53 actually do?
The p53 gene acts as the cellular brake pedal. Its entire job is to monitor a dividing cell, and if it detects a DNA error, it hits the brakes.
It forces the cell to either repair itself or self-destruct.
Exactly. But in this highly toxic resting environment, the p53 gene itself often takes damage and mutates.
The brake line gets cut.
And once the brake line is cut, those mutated cells can divide endlessly. That is the genesis of the carcinoma.
Which brings us to one of the most intimidating diagnostic terms we found in the pathology sources, DVN.
Differentiated vulvar intraepithelial neoplasia. It's a mouthful.
It really is. So if p53 mutations are the start of the cancer, how does DVN fit into this whole biopsy picture?
DVN is the direct consequence of those mutations. It's a high-grade precursor to cancer.
So it's like the immediate stepping stone between that benign callous and invasive cancer.
Exactly. Statistically, DVN accounts for less than 5% of all vulvar intraepithelial neoplasia cases. So it's relatively rare compared to, say, HPV-related precancers.
But the risk factor is wild. The sources say it carries a massive 50% risk of progressing to invasive cancer.
Right. Just for perspective, the much more common HPV-related lesions only have about a 10% risk of progression.
A 50% progression risk is just staggering. But the literature continually emphasizes how notoriously difficult it is for pathologists to actually diagnose DVN.
It's incredibly difficult.
Why? If it's that aggressive, why is it so hard to spot on a microscope slide?
Because of where and how it hides. Diagnosing DVN is like trying to find a termite infestation in the foundation of a house, but you're only looking at the front porch.
Oh, I see.
The cellular atypia, the visual weirdness of the mutated cells that tells a pathologist it's pre-cancer, it's confined strictly to the basal layer.
The very bottom layer of the epidermis, right where it meets the dermis.
Exactly. The rest of the tissue above it, that entire thick callus built by the scratching, it often looks completely benign.
It perfectly mimics ordinary squamous cell hyperplasia.
So the pathologist receives the biopsy, looks at it, and the top 90% just looks like a standard defensive callus.
They have to specifically slice and stain the tissue, looking incredibly closely at that bottommost layer to ensure those mutated termites aren't already gathering.
The pathologist really is the last line of defense there. Seeing SCH on a biopsy means the clinical team is officially operating in the danger zone.
It confirms the environment is actively rusting, cells are frantically multiplying, and they have to be hypervigilant.
Because DVN could already be quietly developing totally out of sight.
Okay, so if a patient is sitting in a consult room staring at a report that reads squamous cell hyperplasia with lichen sclerosus, and we know there's this biological rust destroying their DNA.
And that high risk of invisible termites in the basement membrane.
Right. How does the medical field actually tackle this? Like, what's the action plan to prevent that progression to cancer?
The absolute immediate clinical imperative is to break the itch-scratch cycle.
Just stop the scratching.
It sounds almost too simple, but it is the critical cornerstone of treatment. If you stop the patient from scratching, the squamous cell hyperplasia will slowly resolve on its own.
Because the skin doesn't need the armor anymore.
Exactly. The skin stops building that frantic armor, which drastically lowers the cellular turnover rate, and it gives the tissue a chance to clear out those toxic inflammatory byproducts.
To break that cycle, the guidelines universally point to one specific tool, an ultra-potent topical corticosteroid.
The absolute gold standard mentioned everywhere is clobetasol propionate media 0.05% ointment.
But wait, this introduces a massive paradox that we really need to explain.
The steroid paradox, yes.
Because if you go to a pharmacy and buy like standard hydrocortisone cream, the biggest warning label is that prolonged use causes skin thinning, right?
Skin atrophy, yes. Steroids are famous for thinning the skin.
Okay, so the patient with lichen sclerosus already has skin that is severely thinned out. It's dissolving.
Described as cigarette paper.
Right, so why on earth would the frontline treatment be an ultra-potent steroid ointment? Wouldn't slathering clobetasol on already dissolving skin completely destroy whatever tissue is left?
It is one of the most counterintuitive and honestly beautiful paradoxes in pharmacology. Your logic about normal skin is totally flawless.
But it's different for LS.
Completely different. In the specific biochemical environment of lichen sclerosus, the ultrapotent steroid actually reverses the abnormal changes.
How does it reverse it?
Because the thinning in LS isn't natural. It's caused by that active autoimmune attack, those T cells destroying the dermis.
Right.
The clobetasol acts as a massive, overwhelming ceasefire order to the local immune system. It forces the T cells to stand down and stops the production of those chemical flares.
So the steroid is essentially just suffocating the autoimmune fire.
Exactly. And by halting that chronic inflammation, the dermis finally gets a reprieve.
Oh, so the body's natural fibroblasts can actually get back to work synthesizing new collagen.
The skin can heal and regenerate its normal architecture. The steroid doesn't thin the LS skin. It stops the disease that is thinning the skin.
Which allows the tissue to functionally thicken back to a healthy baseline. That is incredible. It clears up the paradox entirely.
And it explains why the steroid prevents the horrifying architectural scarring we see in untreated cases.
Yeah, the sources detail things like labial fusion, where the inflamed tissues literally melt and scar together, or clitoral phimosis, where the clitoris becomes completely buried under rigid scar tissue.
It's awful. But the clobetasol halts the inflammation before that structural melting can even occur.
Furthermore, the clinical data explicitly proves that regular, long-term use of these ultra-potent steroids is safe on the vulva.
The widespread fear of steroid atrophy actually leads to massive undertreatment, which is infinitely more dangerous than the medication itself.
Because consistent, lifelong maintenance therapy with these ointments is the single most effective defense against that malignant transformation into cancer.
But the human element of this treatment protocol is where things get really tricky.
You mean compliance?
Yes, the concept of compliance. A patient gets the clobetasol, they apply it, the autoimmune fire is suppressed, and the unbearable itch finally stops.
And because they feel better and they're terrified of the steroid thinning their skin, they stop using it.
And that is the trap. Lichen sclerosus is a chronic, lifelong condition. There is no cure. There is only management.
So when the patient stops the ointment, the immune system eventually just goes rogue again.
The smoldering fire restarts, the itch returns, the scratching resumes, the callus rebuilds.
And that toxic, rusting environment starts mutating the DNA all over again.
Exactly. The guidelines heavily stress long-term surveillance for exactly this reason.
Because this is a lifelong battle, any thickened area, any hyperplasia that doesn't soften and resolve when treated with the steroid must be biopsied again.
What the major studies we reviewed pointed out that squamous cell carcinoma in this context is seen almost exclusively in non-compliant or inadequately treated patients.
Wow. So if that defensive callus doesn't go away when you put out the fire, it means it isn't just a callus anymore.
Right. It means the p53 gene is mutated, the brakes are cut, and the DVN termites have taken over.
The biopsy isn't just a diagnostic tool then. It's a surveillance mechanism used repeatedly over a patient's lifespan to monitor the battlefield.
It requires a tremendous amount of patient education. Clinicians have to convince patients to actively manage a disease even when it goes quiet, just to prevent an invisible mutation from taking hold.
So what does this all mean? Let's pull all of this together. We started with a pathology report that just seemed like a string of dry Latin jargon. Squamous cell hyperplasia alongside lichen sclerosus.
But it isn't just medical terminology.
No, it is a profound biological story. It's the story of an autoimmune disease destroying the structural foundation of the skin, causing an agonizing neurological itch.
It's the story of the human body desperately trying to defend against the resulting scratch by building a thick wall of hyperactive cells.
And it is a warning about a high-stakes, toxic cellular environment that breeds DNA mutations, requiring lifelong, potent steroid treatment to put out the fire.
It really highlights the sometimes self-destructive resilience of our biology.
It does, and if we step back, our sources reveal an incredible dichotomy in vulvar cancer that leaves us with a truly fascinating concept to ponder for you listening.
Yeah, this dichotomy is wild. In younger women, this type of cancer is almost entirely driven by a virus, specifically high-risk HPV.
Right. The virus physically integrates into the host's DNA, hijacks the cellular machinery, and forces the mutation. That viral pathway is what we are culturally most familiar with.
But in older women, the cancer is driven by this exact LS and SEH pathway we've been decoding today, which is completely independent of HPV.
There's no virus involved whatsoever.
None. And it begs this profound question about the limits of human biology. Could the sheer blunt mechanical force of an uncontrolled chronic itch and scratch, when combined with autoimmune inflammation over decades,
could it be enough to perfectly mimic the cellular destruction and DNA mutation that is normally only achieved by an invasive cancer-causing virus?
that our own mechanical friction and immune response can essentially act like a viral invader, tearing apart our own DNA from the outside in?
It's incredible when you learn to read the murky waters of a pathology report, when you understand that a patch of skin can be simultaneously dissolving from disease and building armor from trauma. You really start to see the hidden stories in the tissue.
The microscopic battlefield finally makes sense.
Thank you for joining us on this deep dive. Keep asking questions, keep challenging the paradoxes, and stay curious about the incredibly complex stories hidden inside medical data.